All right, welcome to the Oncology Unscripted podcast, episode 1. This is Matt Spraker. This is a new podcast, and I'm doing with a couple of new co-hosts to our system here. And so why don't you just go ahead and introduce yourselves, and we'll dive right in.
All right, I can kick off here, I guess. So I am Katie Coleman. I was diagnosed with a rare stage 4 kidney cancer coming up on 2.5 years ago. And I'm happy to join and be a part of this podcast that we're throwing together.
And my name is Julie Johnson. I was diagnosed with undifferentiated pleomorphic sarcoma, also about 2.5 or 3 years ago. So really excited to be here.
And so you guys are both patients and patient advocates, and we actually both have some history. We've talked before, and you guys have actually been on our other podcast before, the Accelerators podcast, where we did some talk about clinical trials from the patient perspective. And just to give people a little background, the goal of this show is actually going to be a show where we discuss lots of issues around cancer and having to do with this topic. And the goal is really to try to find a show that sort of meets in the middle, that brings both the patient perspective as well as the physician perspective, either from myself or from some of our guests that we'll have. And we're going to do this kind of for lots of different topics. And we feel like it's a unique show because we haven't seen a lot of other things like it, right? I mean, I think that's sort of the goal here, is to kind of get both sides of the story.
Yeah, I'm really excited about the potential to have both sides of that conversation, especially as a patient going through the process, everything from diagnosis, surgery, treatment, everything throughout the entire cancer journey. Oftentimes there's kind of a wall in between the two. And I think that there's a lot of potential in conversations that we can open up and have by having both perspectives on the podcast, which I'm really excited about.
Yeah, we've tried this before, kind of. We've been thinking about things like this for a while. I know that, like, Julie and I have actually talked a bunch over Zoom kind of over the last couple of years. And I found that as we talked more and more, we were getting to the point where you and I were having conversations as if we were peers, because you're so educated on a lot of these issues that we'd have high level medical conversations about it. And it kind of felt like that would be nice to be able to give to people. And then I know, Katie, you and I have tried to do sort of like, patient education type things, sometimes on Twitter Spaces or elsewhere. And it seemed like it wasn't, it seemed like it was good, but we weren't able to record it, or there were other kind of technical issues that made it hard. So we all just decided to get together and start the podcast, right? So we'll see how this goes. We hope to get feedback from listeners that help guide what we talk about. But I think the goal is to be having just candid conversations about all of these issues from both of our perspectives. And so I'm really excited for that, because it's a unique thing. So I think we were going to start today at the beginning with diagnosis, right? That's kind of the start of everything. And we were going to try to frame this by having both of you share your stories. And we were going to just talk about some of the issues around diagnosis, around the way people are diagnosed with cancer, how that happens. And we'll just sort of go from there and kind of see. Unscripted, right? That's the whole thing. It's in the title. So I think Julie, were you going to start by kind of sharing your story, and then we were going to go kind of go from there and see what comes out of it?
I sure can. Everything for me started about this time 3 years ago. I was 39, kind of the picture of health. I was a regular exerciser, really good nutrition habits, non-smoker, not a drinker, no hereditary cancer risk that I knew of. So I had absolutely no reason to believe that I was on the brink of a very serious illness. I had just had a baby, my fourth child. My daughter at the time was about 7 months old, and I was nursing, and I found a mass in my breast. I was no stranger, right? Fourth child, no stranger to things that can happen when you're breastfeeding, like clogged ducts or changes in breast tissue or anything like that. So my first inclination, and a reasonable inclination, was that this was related to nursing. So I gave it some time. And when the home remedies didn't work, I made an appointment with my OBGYN to have her check it out. And she was fantastic. so was very attentive. I never felt dismissed about my concerns. She also immediately was rather concerned about the size and the rough dimensions of the mass and how the mass felt. So for me, it was very quick. I was moved immediately into a diagnostic mammogram and ultrasound, and ultimately, that led to a biopsy. And I remember after I received the biopsy, they told me, we'll call you in a couple of days and we'll let you know the result of the biopsy. Well, my physician called me and told me that the biopsy was inconclusive. And so that was my first aha, because I didn't know that a biopsy could be inconclusive, right? I thought we were doing the biopsy because there would be a definitive answer at the end. So when she came back and said, the biopsy was inconclusive, I was rather surprised at that outcome. So I had to move forward with a lumpectomy, which is where they were going to remove the entire mass, and a pathologist was going to be able to really look at all of the tissue so that we could finally get a definitive diagnosis. I had a hunch that this was probably going to be something more serious after the biopsy came back as inconclusive. And so that's when I really began networking and, connecting with basically anyone that I could. And I'm going to just do an aside really quickly, because when we talk about why we want to do this podcast, for me, learning through networks and learning through my connections has been such a vital part of my strategy from these very early days. And, I've connected with so many patients and so many physicians, and these outlets have been teachers for me. And so networking and connecting is how I accelerated my learning curve and built my knowledge base. And so, when we talked about this podcast, that was something that was really interesting to me, was not only continuing the learning, but also, maybe being a source of information for someone who's earlier in the journey than I am. So back to yeah.
Can I ask really quick? So you actually started looking around, connecting and networking with people when all you had was a lump with an inconclusive diagnosis?
Yes. And yes. And can I just show you this? Because I dug back through my files. I don't know if you're going to be able to see this or not, but do you see all the this is my,
Yeah.
That's impressive.
This was the printout of my biopsy. So the inconclusive biopsy. And I remember spending hours, just any word, I didn't know what it meant. I looked it up. I had a friend who connected me with a pathologist, and she helped me understand her interpretation of this. So I started networking and connecting immediately. It was just my nature. I don't, people ask me why I did that. It was just, it was my nature. I didn't know what else to do. And so I did really take it upon myself to learn as much as I could. Google, I didn't have anywhere else to go. I know some doctors sometimes get worked up about patients who turn to Google, but I didn't have anywhere to turn, and I felt like it was a better outlet than me stewing with my thoughts. So, so actually,
all the doctors that say that, I guarantee you that if this happened to them, they would also be Googling, trying to research and read.
Yeah, it's just natural. And I think it's more about, let's teach people the right ways to find the information so that if they are Googling, they're Googling things that are, trusted resources. But it's funny, I don't think I've looked back at this document since the early days of my diagnosis, and I'm looking back at it, and I think I knew then that every sign in here was pointing to this being something more serious. So after talking with many different people, I actually at that point made the decision to switch hospitals. And I switched hospitals and aligned myself with a surgeon that had come highly recommended by people who were, cancer patients that I had connected with. And so again, that's just another one of my ahas, is that, patients and other people can really be a trusted guide to help build knowledge. I think it's interesting because when I went and saw the surgeon, who's extremely skilled, wonderful, the surgeon was really confident that this was a benign, kind of strange, benign thing. And, she even said to me, I'm 90% sure this is nothing, go enjoy your weekend, and then we'll take it out in a couple weeks and see what happened. And I do think she really believed it was nothing. I don't think she was trying to provide false hope or anything like that. But then again, I also think it was a little bit outside of her expertise area. So that's another aha for me, is really trusting a physician for what's in their area of expertise. And I'm sure that'll come up more as we get deeper into each other's stories. But so I ended up having the lumpectomy, and then that's where I encountered the longest waiting period that I've had to date. I was told I should have an answer within 3 to 5 days. I think it was 2 weeks plus later, and we were still waiting on a result. Finally, after almost 20 days, I received a call saying that my results were back. And this, I think, is another really interesting snapshot. And it's something I have wanted to ask about anyway, because everybody always talks about hearing those words, "You have cancer." It's interesting. I never really heard those words. And so my surgeon was the one who called me, and I still remember the exact words that she used. I think that's like a marker of, how meaningful these types of conversations are. But what she said is, the pathologist is calling this undifferentiated pleomorphic sarcoma. And then she said, sarcoma is a very rare cancer. And then she went on to tell me, we've got one of the top physicians in the country that's here ready to take your case. I've already put in a referral for you. The office will be calling you for an appointment. But that language of the pathologist is calling this, I've always thought, I've just wondered about the amount of calculation that goes into how physicians deliver this type of news. And I actually like the way that she positioned it to me, to be honest. And then I really liked that she followed it up with reassuring information, like, we have an oncologist who's very skilled in this disease setting. He's ready to take your case. I remember her using those words as well. So of course, I had all the feelings that come along with having a cancer diagnosis, being shocked, being discouraged, being sad, feeling like my whole life was in a tornado. But I also felt like I was in a good place based on the words that she had chosen. And she made me feel like I was being set up to be cared for well. And so that's really how I officially entered the system as a cancer patient. The first stop after that phone call was a PET scan. I don't know that I really even understood what I was doing or why I was doing a PET scan. I knew that I had to have a PET scan. Now I know why, but I don't think at the time it was clear to me that what we were looking for was evidence of possible disease outside the breast, which is the area that we knew about at the time. And this also was a really different experience, from my biopsy. So with my biopsy and with my lumpectomy, there was long waiting periods. There were weeks after the lumpectomy where I was waiting for a result. For this, when she called me, she already had the PET scan booked. I was having that PET scan less than 48 hours later. I was told that all I needed to do was have the scan, and in 2 hours I should show up at her office. I wasn't going to have a regular appointment, but once the scan results came back, she was going to come get me from the lobby and share the test results. So, and that's exactly what happened. I had my PET scan. Probably 2.5 hours later, I had the results. and knew at the time that we didn't think there was spread outside of the breast area. So at the time, we felt like we were dealing with a local situation. I did have to have some further testing. Matt, I don't know if you remember this, but there were some spots that showed up in my legs. And so I had to have a couple of MRIs in order to rule out that those, whether or not those were other sites of disease, but it seemed like a very low chance that they would be, and they weren't. So those ended up being something completely unrelated to the cancer diagnosis. And so at that point, once we had that information, then we were really ready to start building an action plan. And that's when I started meeting with my care team, starting with surgery, because we knew that surgery was going to be kind of the cornerstone of my care. And then I also met with a medical oncologist. My medical oncologist felt like I was on the borderline, actually, of needing chemotherapy. And we can get into that conversation, because that is, that was a whole conversation in and of itself. But
one thing that's actually true for both of you is, and we'll get into all of this. I think I know more about your diagnoses than the audience does at this point, but they're both unique in that they are quite rare. There's not a lot of guidance on the right thing to do, and there's maybe a little more guidance for you, Julie, than But among that guidance, there's significant disagreement about the right way. And so I also remember you had gotten a second opinion in another institution. They actually gave an opposite recommendation as what we gave. And that was just interesting as well. And so we'll definitely get into all of that. But I think that's past diagnosis and probably.
Yes. Absolutely. I mean, I've gotten multiple pathology diagnoses that were different. I've gotten multiple treatment recommendations that were different. So I'm sure we'll cover that. But
so one question I had for you was real quick. So like when you were between biopsy and lumpectomy with this inconclusive breast mass, I'm guessing you were interacting with breast cancer people. Is that right? And not sarcoma people?
Oh, yeah. No, sarcoma wasn't on the radar at all. I was interacting mostly with either breast cancer people or just general cancer connections. Like a friend of mine worked in the medical field, and she connected me to a pathologist who practices in a different state, but was more of a generalist, who was able to kind of walk me through what some of the terms mean and things like that. So I stayed pretty general at the beginning.
Okay.
Because I wasn't sure what I was dealing with, but yeah, I mean, I was pretty sure that I was dealing with something more like a typical breast cancer.
Yeah.
As you were sharing your story, there were so many, there's so many spots in this that I feel like as we continue to define like what this podcast is, I think it'll be like really good for us to even just like talk on a topic and then like discuss everything on like, there's just so many things in these tiny little bite-sized pieces. Like when you were talking about your biopsy and how you started looking things up before you even knew what it was. I literally just made a YouTube video on this because I did the exact same thing as I went back and was trying to retrace like how I connected the dots as I was going through the diagnostic process. And I connected mine from my CT scan that came in the ER. The radiologist had put on there that it could possibly be chromophobe or an oncocytoma, which is not something that's typically listed in a CT scan because it's not something that's you usually can tell from imaging. And I took those words and everything that was in my pathology report, and one by one, I didn't know any of it, but I like Googled what each term meant. I connected with pathologists on Twitter. I did the exact same thing that you did. And so I think that like the network piece that you pointed out, I think is very crucial and important because I feel like it's changed my care a lot. I think it changed your care and how involved in your care you are. And so I think talking about even just the network piece could be really valuable for people to learn from. I'd also be fascinated, Julie, to hear your opinion and if you think because it sounds like you were kind of diagnosed like right at the beginning of the pandemic as well. And so I'm curious if that influenced anything for you. I know for me, somebody recently asked me like who my biggest community was that was there for me through my diagnosis. And so much of my community was online. And I spent so much time in these networks, I think as a product of the fact that my community had to be online through the diagnostic process. I'd be curious if you think that influenced yours at all.
Yeah, so I was diagnosed in July of 2019, so a little bit before the pandemic was underway. I went through some treatment outside of the pandemic, but when I was going through chemo, I went through chemo during the pandemic.
Mm-hmm.
And so I would say most of my cancer connections are online and people that I've met just through various groups on different social platforms. I think the way that I was cared for, more broadly speaking, I do have a lot of local connections that were really helpful to me. But from a cancer perspective, from a learning perspective, from connecting and networking, that's almost solely been online.
Yeah, I think it's interesting because I wonder, did you ever do an in-person like support group or anything? I mean, these kind of
Yes.
oh, you did? Okay. Because a lot of these
Yeah.
groups actually have went away and they're even just now coming back or maybe even still not back. So they basically have been they've gone away, and I think I have to wonder how many people benefited from those groups up front even before the pandemic, even before they went away, because like, for example, if you landed in a breast group, which I don't know, is that what, did you go to that or did you end up going to like a support group for
I just went to a general cancer patient support group.
Okay. And was it one that was for like adolescent, young adult people,
No.
or was it everyone?
Anyone.
Yeah. And so I think you probably can get a lot of support from those, but I think the specific information you were looking for, like, for example, defining these terms in your report, like you said, it's hard to get that out of a support group, I think.
Yeah. And, there were different goals to the support group. I did that for more mental health reasons, where the connections that I was making were more for learning and kind of knowledge building.
Yeah. I don't know. Okay, Katie's still there. We were chatting in the chat because Katie had to turn off her video and we didn't know if she left or still there.
I literally just had construction, like the loudest construction ever that started out my window. And I'm like, worst timing ever. Had to go and move to a quieter place for a minute.
Well, I think it's okay. We like informal, right? That's what we're doing here. So it's good. It's the real life. You have informal. I'm sure I'll get like paged at some point during this. So I think I think there's a lot, like Katie said, there's a lot of stuff that we could talk about there that you had brought up and mentioned. I wonder if, Katie, is now a good time for you to kind of tell your story, and then we can kind of circle back and talk about some similarities and differences. Because one of the things that I thought of that is hugely different is that, Julie, you were diagnosed in a very regimented setting. And what I mean by that is breast centers are probably the most regimented place that people are diagnosed with cancer in our system, because they are, first of all, they're often staffed with excellent doctors, and they have radiologists that will interface with the patients and explain things to them, do the procedure. We don't always have that outside of breast centers. And then they're, just by the way they're set up and by the way the billing works, they are very organized, right? They keep registries. People don't really fall through the cracks. There's a very stepwise progression of getting biopsied. And then, you had an unusual result, but the point is that the connection from the breast center to your surgeon, that's very rigid and that's very stable. Unlike if you're diagnosed in other settings, like, for example, where Katie was diagnosed, it's not always so organized, right? It's not the fault of any doctor. It's just the way the hospital is set up. And so
I've actually always felt kind of grateful that I had the experience that I have. I know even in sarcoma, there's such a high rate of misdiagnosis or delayed diagnosis, that I really believe my story would be very different if that lump would have been anywhere else in my body. So,
Yeah. That's true. And also, to your surgeon's credit, like, it's probably true that 90% of the time those lumps are benign. And
100%. Yes.
And I think a lot of people say expertise, but one thing we'll talk about repeatedly on this podcast is really what people mean is experience, right? Because doctors, like, they can be experts, but really they're just experts because they do a lot of whatever we're talking about. And so if you're a breast surgeon, you take out a lot of benign masses as part of your job, and you take out very few, if any, sarcomas. And so, the good surgeons will say there's a 90 or 95% chance. They'll never say 100 because they know medicine will always burn you if you say things.
Well, and she did, right? She's
right. And so, quite unusual. So Katie, do you want to tell us a little bit about your story? And then I know that you've documented a lot of this online. Maybe you can give the listeners a high level overview.
Yeah, I'll just give a quick run through because I think there's a lot in like the dialogue along these scenarios that I think could be beneficial. So just as a high level overview, so I was diagnosed at 29, and my diagnosis actually came in the ER. I had been feeling off and been experiencing kind of just different symptoms that I had been trying to track down for about a year and a half. And everybody kind of just chalked it up to anxiety or different things, like maybe related to my menstrual cycles, as well as we were kind of stepping through a bunch of different kind of diagnoses, and the biggest one we were trying to rule out, I guess, is anxiety, which I did have anxiety, and that only kind of compounded this whole issue when I knew that this was different. I had struggled with anxiety in my life before, and the feelings I was feeling was different. One of the biggest symptoms I had a rapid heart rate and high blood pressure, and they felt different to me than kind of other things that I had experienced in the past. And kind of this is one of the things that I'd love to have us talk around in general. I was diagnosed at 29, and I really did not have any idea of how the medical system worked or really kind of anything health related. And so as I was going through the diagnostic process, like, I remember asking several physicians, like, could this be cancer? Can we rule out cancer? I had slightly high platelets, which in itself aren't really super valuable, but like, especially now when you go look back at my history and what my baselines are now, I definitely had elevated platelets in relation to what my baseline is. But those physicians, through the workup process, like, there's multiple of them that told me I'm too young for cancer and this is just anxiety. And so that in turn made me kind of downplay my symptoms a lot when I'd present them, and when they would kind of be dismissed as something else, I'd start to downplay them when I brought them up to the next physician because I didn't want to feel like I was wrong. And so that whole process took about a year and a half. And then my husband and I ended up getting married, and we were building a house in a new city. And so I was going through one final kind of workup process to try to make sure everything was clear with my health so that we could start having children. And so I got a new primary care doctor, and I had started to feel a hardness in my upper right abdomen. So I had mentioned all the other things that I had been dealing with to this primary care physician, and then also mentioned this hard mass that I had started to feel. And they weren't too concerned about it. And I just didn't feel right about that. So I kind of sat with that for about a day or two. And then I ended up deciding to go to an urgent care to have it looked at. And in the urgent care, they thought it possibly could have been an enlarged liver. So they sent me they told me I could go back to my primary care doctor or the ER. Since my primary care doctor didn't really seem too concerned about it, I chose to go to the ER. And then the minute they put an ultrasound on me, they found I had about a 12 centimeter tumor on my right kidney. And then I had we didn't know at the time, but it would end up being about 15 tumors in my liver. And so they knew kind of, I got in the conversation right there in the ER that this was likely stage 4 kidney cancer. And that was kind of without having a biopsy or anything like that, just based on how large this mass was on my kidney and how many tumors I had in my liver. They did tell me like there was a possibility that it could be benign and what was in my liver could be benign, but that most likely it was stage 4 kidney cancer. And so that all happened on New Year's Eve for me. And so there was some delay getting into the new year to try to get in for appointments. And then I had my very first appointment with my oncologist, who basically just said we need more information. And so we scheduled an MRI and a biopsy from there. And we did a biopsy of both my liver and my kidney. And I actually had a complication. I had didn't know I had a bleeding disorder at the time, but we found out I have a bleeding disorder. I had a small bleed during the liver biopsy that I was hospitalized for just a day. And then I ended up getting my results back from that biopsy, I want to say 5 or 6 days later. My oncologist called me to let me know the results and basically gave me the impression that it was rare, but I don't think we necessarily discussed how rare it was. They told me that it was a metastatic renal oncocytic neoplasm. And so I don't think I had access to my report quite yet from that, but immediately I did the exact same thing you did, Julie, and started Googling what that was and tried to start putting pieces together. And then I would end up with tons of second opinions, and we can go into what that ended up being. But basically, I ended up having a metastatic oncocytoma, which was listed in my pathology report as exceedingly rare, because we think I'm currently the only one alive in the U.S. with my official diagnosis. And there's under like 10 case reports worldwide that are kind of listed currently. So that obviously led to lots of second opinions from there.
And the first oncologist you saw was like a local doctor? Because I know that you go to a big center outside of your city.
Yeah. So I started in Utah. I got diagnosed and I was living just out of Salt Lake City, Utah. So I went to the Huntsman Cancer Institute, which is incredible. It's an amazing facility. And it was a GU oncologist that I saw. But talking about, I know we talked a little bit earlier about second opinions and the thread that we all kind of chatted on Twitter about ways to ask for second opinions. That oncologist was actually incredible with that. I was very nervous to ask for a second opinion because I had no idea how to navigate that space at all. And he was very, very encouraging and supportive of that, which is something that as a patient, I was very grateful to have because I knew nothing. That was one of the things I was going to mention and ask you about, Julie, is I remember one of the first things I did is I was trying to look things up and learn and understand the process to get diagnosed. Julie, you mentioned that you weren't really sure, like the PET scan, like what that, like why you were really going for that. I actually had the opposite. I was wondering why I wasn't going for a PET scan because kidney, like I saw in these general support groups and just generally when it talked about cancer in general, pretty much everybody was going for PET scans. Yet kidney cancer, they were sending me for just a regular CT and an MRI. And so I was wondering, like, are we missing something? What's happening here? And so I think I'd be interested to know if you knew kind of what that whole process was, Julie, as you were working your way through.
No, I didn't. All I knew is that I was being sent for a PET scan. And my appointment was already set and that I didn't really know why I was going for that. I do remember the first place I went, and I'm kind of embarrassed to say this, but the first place I went after I got the diagnosis was Facebook. And I actually found a group on Facebook that was called Undifferentiated Pleomorphic Sarcoma and Spindle Cell Cancers. And that was the first group I joined. And like within hours, I had been connected to multiple people that were already helping me put some of these pieces together. But initially I wasn't exactly sure what was going on other than I needed more imaging.
I don't think you should be embarrassed by that Facebook. No. I did the exact same thing. I joined the like chromophobe kidney cancer Facebook group before I even had my biopsy. I think it's a great resource for patients.
It's pretty well known too among like doctors that go online. I think people kind of know that that's where patients go is Facebook. And then, we're all kind of on Twitter, but that's where, to me at least, Twitter is mostly like doctors and very sophisticated patients that are either advocates or, interacting with the doctors. But most of my patients that tell me they go online, they go to Facebook. And so I wouldn't be embarrassed about that at all. It's kind of what people do, I think.
Well, it's just that it's interesting that was the first place I went. Like, I don't even think I Googled anything. I just opened Facebook and searched for a group because I felt like I think I will find somebody. I felt like that was my surest route to being connected to someone. Right. I think that's what I wanted, was connection to a person. I don't think I really at the time wanted connection to information. I kind of wanted to know that there were other people out there like alive that had what I had. I didn't even really know what I was dealing with in terms of a prognosis or anything like that, but I just felt like I needed to know that there were people like me out there somewhere.
I think it's funny because it's an important point, because Facebook does not have a good reputation of being a place that has reliable information, right? It's like,
right, which is why I said, like, I'm kind of embarrassed that I went there, because I know now I know the reputation that it has, but I've met amazing. I think if you go to the right places, it can be a wealth of information. At least for me, it has been.
If you're looking to connect with somebody, that's probably the best place to go, right? Because it's like kind of where everybody is, I think.
Yeah.
What I was going to ask before was, you both brought up that you had to get staging scans, and we should talk about staging because I think you both had stuff. This is like a nice contrast about, it explains how we stage people. And what I mean by that is, once you have a diagnosis, you kind of have to look and do imaging for pretty much every cancer to kind of see where it is in the body, what its relationship to other organs and things like that. So Julie, you were sent off for a staging scan, before even talking with an oncologist about why they were getting it. And then Katie, you showed up to an oncologist appointment without the scans that were needed to give you recommendations. Do you have thoughts about which, because that happens a lot. I mean, I'm a specialist that I'm a radiation oncologist. I don't know if I said that at the top of the show or not. And I'll take a lot of opportunities to try to educate people about radiation on this show, because it's definitely a need. But we're kind of at the end of the line. Like, we usually are not the first person to meet people and talk about their diagnosis with them. And it's not infrequent at all that I will have, or, quote, make patients get the imaging that I need prior to my visit, because otherwise I feel like I bring them in just to say, we need more information. I'll see you in 2 weeks. So I guess my question is like, do you feel like that aspect, like, is it better to, you know what I'm saying? Is it better to have the scan without the knowledge of why you need it, or better to have the knowledge, knowing that it's going to be a couple more weeks to get the real answer you're looking for?
I will always want the scan and then the information, like knowing what I know now. I am fine with the way that it happened, where, for me, I got a phone call on a Tuesday and I was getting a scan on a Thursday, and I was straight into that surgeon's office Thursday afternoon, getting my results and having at least an understanding of surgically what the steps were that we were going to take. So, I don't find it very helpful usually to meet with a physician only for the physician to say, we need X, Y, and Z tests or scans before we can really get to a treatment plan.
I don't know. I think this might be interesting to get your perspective on Matt as well. But for me, I don't know which one I would have rather had, because for me, it took a couple weeks to get my MRI scheduled for additional information and then my biopsy. And so I would have been waiting for like 3 weeks being told in the ER that I had stage 4 cancer. And I remember like one of my biggest fears, I knew nothing about cancer when I was diagnosed. And so one of my biggest fears was the fact that even going from, I think it was like a week or a week and a half from ER to that very first appointment. And I had I didn't know if the cancer could kill me in 7 days. Like I literally didn't even have that context to know what to expect. And so if I had waited several weeks, I think that would have been a lot harder for me, even though I didn't, that first appointment, I left feeling a little bit disappointed because I thought I was going to have answers and know what my treatment options were going to be. What I wish existed is I wish there was more communication about whatever stage you're in. So if your first appointment is going to be for more information on what scans and things you're going to need, for that to be communicated, that's what that first appointment is. Or if you're going to have scans first, have that communicated of like, we're getting these scans and then we're going to meet with you because we need these scans to make our treatment decisions. I feel like a lot of that context is lost because it goes straight to a scheduler versus like actually talking to a physician. And the piece that I think would be interesting to hear your perspective from, Matt, is I know for me as a patient, I was really, really confused at my first appointment because my oncologist had said to me, like, we want to get you an abdominal MRI and a brain MRI as soon as possible. Like, let's get you in immediately for those scans. And I actually remember like almost having a breakdown when I was sitting at the scheduler's desk, because when I went to sit down at the scheduler's desk, they're like, okay, well, the next appointment we have is a month away. And I was like, that does not sound like immediately. And so I ended up having to like work really hard to get, I booked, I think 3 weeks out, and then ended up getting my scans moved by getting on wait lists and things like that. But I also think that there's triaging. I feel like that happens on the side that Matt, you might be able to speak to a little bit more. But I remember as a patient, like I hated that. That was like one of the worst experiences I had because I felt like I had fallen through the cracks up until that point to get the diagnosis. And then going from hearing you need these scans immediately to you're going to have to wait a month, I felt like I was falling through the cracks again.
Yeah, I think, Julie, were you going to say something? I think.
Well, there was a whole part that I kind of left out of my story, which was very similar to what you just talked about, Katie, which was there were times where I had to wait. In fact, I ended up having like my mammogram, my ultrasound, and my biopsy all very close together. But initially there was like a 3-week wait there. And every single day I called the center and asked if any cancellations had happened. And they didn't run a waiting list. So you had to call every day. So I called every morning on my way into work. It was like my habit that I would call every morning and I would call every afternoon. And after like 3 or 4 days of calling, the scheduler actually called me and said, I'm trying to preempt your call today. Like, we have a cancellation at 2:00 and I know you will be calling me. So do you want it? And I'm like, I'll be there. And so I can relate to that idea. And then I can relate to that idea of kind of like stalking the wait list a little bit, because I did that not only on the early parts of my like mammogram and ultrasound, but I also did that after my PET scan when I had a couple places in my legs that showed up on the PET scan that people were curious about. And again, that I would have had to wait 3 weeks in order to get those scans done. And so I remember having to call multiple places in order to try and kind of piece together something that would give me those results sooner.
Yeah, and I think it's actually a loaded question about that process, and I think it's a lot of it depends really on the doctor and the clinical situation. And I'll kind of explain this a little more. The setting, I think, where you are. So like, Katie, were you in like at the point that you had seen this oncologist, was it just like an office, like an outpatient office, like kind of not linked to, like not in a hospital? It was basically
I mean, it was at the Huntsman Cancer Institute, which was tied to the University of Utah.
Okay.
Yeah.
Actually, so it's actually pretty similar. And then I know, Julie, you were at WashU at Siteman. And so I think that, that's different than if you're like sitting in an office. And then the last thing is Katie, when were you diagnosed again? What New Year's Eve was it? Or what New Year's?
2020. So it was like, there was a lot of backup and things happening.
And that was like deep COVID. So the caveat here is that I think, I think there's some sense that things have changed permanently since COVID. So I don't know that we're going to get back to where we were in 2019 or 2018, but definitely, especially with imaging and getting things scheduled, it became way harder in 2020 than it was the year before. So I think there's a couple things. One is that when people say immediately, they don't always mean like the next day. I think they just use words. And I think we have to be careful as physicians with words in the clinic a lot, because we'll say things in passing. I do this a lot because I'm a pretty open person. I just say what I'm thinking all the time, which is not always the best. And so immediately might just mean like, don't go off for 2 months and then come back and do it. But the patient certainly can be like, I need this tomorrow, right? So that's one thing. The other is that a lot of these bigger centers, like for certain cases, you can just call up the nuclear medicine doctor that does the PETs, or you can call up the radiologist or the department and just explain like, look, I know you have a full schedule today, but I have a new diagnosis of a rare cancer in someone who's 29. Like those are, I think, all the people are human, right? And so there is an aspect of like, when there's a case that's unusual or a case in a young person, things that are just outside the norm. Remember that in oncology centers, most patients are older. That's kind of most of what we see. And so I think that, that those are times where doctors will, do exceptional moves to try to get people in quickly. And just to clarify, I don't mean like that they don't give exceptional care to all their patients, but I think any human being can understand that rare cases that fall outside the norm, you might, treat it a little differently. And then at a big center, it's just easier to communicate, right? So if there's listeners or patients that get diagnosed in a radiology center that's freestanding, and then you go to like some office that's a different company, and then you need to go to a different radiology center that's a different company, that doesn't mean that care is going to be worse necessarily, but like those centers have to all work extra hard to talk to each other, versus at both of your settings, like you can just put an electronic order in and it goes, and then that's easy to get set up. And so I think that it's a pretty heterogeneous experience probably for people. And I think that's sort of, that's sort of what it is.
I think we should pause. I have two thoughts on this, but one of them, I think you should pause and explain what heterogeneous, I can't even say it right
heterogeneous.
Now. Yes. Because that is a phrase that I saw everywhere when I was first diagnosed. And I was like, what in the world does this mean? And you as physicians use that term all the time. And it's pretty basic, but it's a big word that I didn't understand.
When you enter meds, was there another thing? You said there were two things, right?
Well, I think you should answer first. Yeah.
Well, so it just okay. So the definition of that term just means that things are variable or different, right? And so when something's homogeneous, which is the opposite, I don't know what the name of that is. When something's homogeneous, it's all the same. Heterogeneous means that it's different or mixed or things like that. And so I can't remember even what I used it in a couple minutes ago, but that's what that means. And to your point, can I just to reassure you, when you start medical school, if there's doctors listening, they probably will agree with this. They tell you learn a whole new language over the 4 years of all these different terms. And that's totally true. And I'll use them now as if they're second nature. And I forget that like so many of them, and they might not even be medical terms, people just don't know what they mean. And there's just a lot of stuff there. And then as a side note, anyone that's a spouse of a doctor, like you'll know these terms only because you hear them say them or practice them or whatever over the years. And so like my wife, for example, who's not medical, like knows a lot of these terms just because she hears me say them in passing or things like that. But thank you for pointing that out, because that's something that we do a pretty bad job of.
Yeah. So that was going to be my second point, was the fact that like words matter. And so that's what I wanted to call out, was because I think it's very easy, like for something just as simple as like that interaction, to make a patient sometimes feel like, oh, I don't like this all sounds like over my head. I don't know if I can understand this concept. Yet it's something that's like we're talking about something that's variable. Like what you were trying to convey was something that can be very easily understood. It's just the language that's different. But also words matter in the concept of like what you were just talking about of like, we need a scan immediately. Saying you need a scan immediately to a patient that was just diagnosed with stage 4 cancer and doesn't know anything about that, or is, I mean, honestly, if a physician told me that now, I would still have the same interpretation of like even being where I'm at in my diagnosis now, probably because I've learned a little bit more and feel like if somebody tells me immediately, they mean immediately at this point. But so like words matter in that context, I feel like, of like making sure that like even that word can cause harm, right? Like it's harm to the patient as far as like the kind of mental battles that they end up going through after replaying the words that are said in the appointment over and over again, which I don't know if this is something that you do, Julie, but it's definitely something I did it over and over again, was replaying everything that was said in that appointment over and over in my head to try to understand it. And then the other thing that I kind of wanted, like, as I've learned through my diagnosis, which is not something I knew when I was first diagnosed, that speaks to the kind of the scheduling of scans. Later, once we kind of figured out what I had, and I mean, nobody knew really what to expect because what I had was so rare. But since oncocytomas are typically known to be benign and they're typically known to be slower growing, we didn't think I was in the same spot as somebody who has like a really highly aggressive stage 4 cancer. And so over time, like my appointments would get pushed out or a triage, or like I wouldn't be the immediate person to kind of be seen. And as a patient, I didn't really understand that and didn't know that there's kind of like a logic or a triage that can happen behind the scenes. So I was left sometimes as a patient wondering like, okay, this person is getting seen in X amount of time. And this is kind of what I saw in like Facebook groups and stuff like that, Julie, of like you not understanding the context of your own disease to the context of what somebody else is going through. And so I think there's also talking about scans and different things like that, even getting in for an appointment. I believe, and Matt, you can probably talk to this a lot more than I can, but there's kind of a triage that can happen there too, of like a patient's going to get in immediately if they have something that needs to be seen for immediate, say like a side effect that needs to be addressed like soon as possible versus something that can be managed in a little bit further time frame.
Yeah, I think that's true. Yeah, I mean, I think that if it's a new patient, there, you do triage a little bit depending on what the diagnosis is. As a great example, a lot of radiation oncologists, a big part of their job is treating patients for when spots of cancer cause pain or symptoms. We do what's called palliative radiation. And so those people, I'd say any oncologist just universally will get people in very quickly if it's pain, right? Because we know that pain is a huge hit to people's quality of life, and we want to get that taken care of quickly. If it's something like a slow growing cancer that something changes and you need to act on it, even if the patient's like, I have this vacation plan next week, we say, go on your vacation, come back, we'll deal with it when you get back. Because so that kind of thing, it really is personalized, and there's just a lot of factors that go into it for sure. And then additionally, kind of what I said, it's like the type of, this is going to be misconstrued. It's really hard to say it, but I think that like that again, it's like if it's something that falls outside the common thing that people are seeing all the time, I think that generally sometimes people will get it in quickly and try to get it going and that kind of a thing. There's actually other aspects for new patients that are probably outside the scope of this podcast that are more related to like the business of medicine. Like, a lot of centers, if you're, a lot of, both of you actually came from diagnoses that happen kind of in a separate setting. But if you have a patient that is like screening for cancer, for example, and they're diagnosed and they come from primary care, you often want to give good service to that primary care doctor because they refer to you, and that's part of the US kind of system business of medicine. And so there's motivation to get people in quickly so that the doctor that's sending you the patient perceives you to be good, and your patients are happy and everyone's happy. So that's kind of like what that kind of stuff goes into it as well. So I hope that's not misconstrued and spent out on the internet. That's kind of the real thing, though. There's a lot of factors that go into like triaging and stuff like that. So, yeah.
I actually had a question for you, Matt, back on the topic of words matter. can you talk a little bit about how you guys come up with how you're going to break this news to patients? Like, do you deliver it in the same way all the time? Like, I remember when my surgeon called me and I just felt like she had a very calculated way of saying you have cancer, right? The pathologist has looked at your tissue. The pathologist is calling it X cancer. These are your next steps. I'm just curious how that all develops behind the scenes.
Yeah, so I should caveat that I have a unique. Again, I rarely break bad news to patients because I'm kind of a very specialized type of doctor that most of the time people have cancer already when they come to see me. They kind of
You
know.
broke bad news to me.
Oh, yes, you're right. Yes, you're right. So I
can tell you how you did that.
Yeah.
It was really good. Actually, it was really good.
At the end of this, you should, and we should be honest about this because I will just tell you up front that I don't know that I do a great job of it, and I am always working on it. But I'll tell you a couple of things that I think of. You learn this, right? So you absolutely learn this in medical school internship, which is a more generalized year where you do lots of kind of different types of medicine in the hospital, and then in residency. And again, understanding that I have less exposure to this than, for example, a medical oncologist who often breaks bad news to people. You learn through role models. There's no class really about this, or if there is, it's a very limited setting, or you might have like a patient volunteer that comes and talks about their experience, and you kind of try to learn from that. And we talk about positive and negative role models in medicine. So you learn by watching people who do a bad job, and you learn what not to do. And they do a bad job at watching the patient's reaction, because you'll see that right away. And then you learn from people who do a good job. And my perception through all of my training was that people beat around the bush a lot when they are getting ready to give bad news to someone, and that tends to go poorly most of the time. And so when I was a resident, I had a faculty member and attending that I was a resident with. We are an apprenticeship model, so you spend like some time one-on-one with a person, you kind of do their clinic with them. And this guy, he was a brain tumor specialist, so a lot of breaking bad news to people. And was very direct. Like he'd walk in the room and say, I like to be very direct with people. And most people would be like, give it to me, tell me what you want to say. And then he would just tell them. He would just say, you have a brain tumor. It's a bad brain tumor. Here's the outcomes, and here's how we're going to treat it. And people seem to really appreciate the directness of that. So I would say that is probably the biggest influence, where I try to, it goes along the same thing of walking in the room and giving people their scan results right away, because it's like nobody like wants to come hang out at the hospital. Like, they're there to get the thing done and then go home. And so for me, I feel like giving someone what they're waiting to hear and then dealing with it is better. Certainly people can get upset, but I never witnessed someone getting less upset when a doctor kind of beats around the bush a little bit and like before kind of saying it eventually. I don't know if that makes sense, but that's sort of my take on it. I think I do remember now that we had to deliver some bad news to you as well. So hopefully it wasn't like,
no, it was fine. And actually I remember, this was a recurrence that I had after my original diagnosis, but I was receiving radiation at the time. I remember you actually gave me your cell phone and you told me to call you on your cell phone. And I called you and interrupted a meeting, and you said, hold on, I'm going to step into the other room. You stepped into the other room and you said, it looks like this is a recurrence. Here's what we're going to do about it. And I was actually on my way to radiation. And so it ended up changing a little bit of the course of how we were going to treat moving forward. But, I think you were available, you were direct, all of that. It was fine.
Yeah. And I have you guys had experiences of people where because I think it's probably worth saying that there are like levels of bad news, right? Like, I think that you get news multiple times along your, can I ask, so here, let me just really quickly ask a side question. The term cancer journey, is that like a good term or a bad term? Because any thoughts on that at all? It's about what I was about to say.
Heated. Somebody asked me this literally last week too. I think it depends on the patient. I personally don't mind journey, and I use it myself because I literally don't have another phrase for it. So I don't mind it at all, but I don't know, Julie, if you have a better one.
I don't mind it. I wish there was a better phrase.
Yeah.
I don't know what the better phrase is. So it serves as the default for me.
Yeah.
Because it's not like voluntary, right? It's not like you're going on a trip. Like it's, it's so, well, anyway, what I was going to say is that along your cancer journey, which we've said we'll say it's okay on this podcast, is that you will receive different like news, right? You'll like throughout, and some, probably I would guess that the initial diagnosis is probably the hardest one. And so I think, to be fair, the one that we talked about with a recurrence during treatment that we had a solution for, is a little different. But I guess, you both seem like you prefer the direct method, I would guess.
Yeah. I have I was trying to think through my experiences because we didn't know what mine was for so long. I actually had a lot of these conversations with a lot of different doctors. Like my experience that I had with my ER doctor was probably like the top experience from all of them that I had, because it was very, very genuine, or at least it felt that way. It did not feel like, I'll kind of explain in a minute some of my other appointments. Like I could tell that like, okay, this person has delivered this kind of news before. This is their cadence and what they say. And like kind of falls into that criteria. That didn't feel that way with this ER doctor. Kind of felt like he really did not want to be breaking this news to me, but he had to. And he like pulled up the stool next to the bed and kind of like very intently like got my attention and was like, I'm really sorry. And let me know that they had found a tumor and that it looked like it was in my liver as well, and kind of explained a little bit about what that was. And then he also shared an experience from a family member of his as well, which meant a lot to me. I know not everybody likes to hear those experiences, but for me, it felt like very personal, because he's like, this is really personal to me. And like, this is why. And that felt very relatable to me. And I personally liked that. And he was like the first doctor that I ever felt took me seriously, and I could really feel his empathy. So I'll say like that first, I actually had a harder time in my first appointment with my first oncologist than I did in the ER. While I definitely cried in the ER, the magnitude of what I was dealing with hadn't really hit me yet. And it was more his empathy that was kind of comforting me through that moment versus like the diagnosis hitting. Whereas because we didn't know what I had, my very first appointment with my oncologist felt kind of like the bad news. And then I got a second opinion at MD Anderson. I switched oncologists and got like another opinion at MD Anderson. And then I also got an opinion from NIH. And so I kind of got the delivery of my diagnosis several times. And I agree with the direct part. Like I really like and appreciate direct communication, but I'll say I did have one physician at one point that was very direct in communication, but they didn't say that they were direct in communication, or like didn't communicate that that's their communication style. And it was harder for me to process that because it felt less personal. But then, yeah, I don't know. I have so many thoughts around this because I've sat through so many second opinions and heard so many different ways to have this delivered. I've even had the experience where like I've heard the words that were said in my appointment. I've heard another patient who like had the same provider echo very similar words back to them. And so like I think that kind of falls into kind of maybe what you mentioned, Matt, is like you pick up on what works best to deliver and kind of use that for delivering. And I think that
yeah, you can be too direct. I had a good experience with where I was rotating with someone. That's the term we use when we talk about like kind of working with a faculty physician and when you're in training. And it was an extreme example of being too direct. The person burst into the room without even saying hi and said, "You don't need radiation." And this person had driven like 3.5 hours to see, because I was a big center, it was a specialist center. And so, and that was one where I felt like I had to stay behind and kind of talk to the person and explain all of the information that they needed to understand why they don't need radiation, because that was like way too direct. So I think that you can take it one way or the other. The only other quick thing I wanted to say is that I do feel like it's always learning, because they're even now, like, I feel like I'm okay at it for most people, but I still have visits where like it just did not go well. And it was just the way that, I said it or whatever, or things like that. Or sometimes, honestly, I think that it seems clear that patients prefer a style of physician or a physician to act a certain way, and they like it or they don't. And I think that's part of what goes into this second opinion discussion, which we have to do a show on, by the way, because you did these polls and it was so interesting. But I think that like I tell my own patients that if they want to get a second opinion and they end up going with that person because they like them more, like even if medically we're recommending the same thing, that's worth something to me, because I think that it's, we'll talk about this as we go, but things are a lot less complicated than doctors want to make it seem. And the reality is you can get good treatment in multiple places. And so having a doctor that you're comfortable with and having them have a style that you prefer, I think means a lot. And with all the problems that we have, one of the things we do have is like all this choice, right? Where you can kind of go to different places and see the doctors you have. So you might as well, I think that should be leveraged, and people, if they have the ability and means, they should be able to do that, I think.
Yeah, I think it's really important, the relationship, like in the rapport that you have, especially when it comes to like receiving the news. I'll also say, like, even as a patient myself, the same delivery might land differently depending on the day and where I'm at and what I'm dealing with. And so I don't think it's fully in control necessarily of the physician as well, either in those scenarios, because there's been some news that has been delivered to me that was like super minute, something that like would not upset me, but I'd had like so much buildup or like so many other factors playing in that like the smallest amount of news would trigger like emotions. And like I know on a previous podcast we've talked about like PTSD stuff that comes from cancer. And so I think delivery matters, but also I 100% agree, like the rapport matters, because the rapport can be a lot more important than I think even the delivery.
Yeah. So I don't know, did you guys have I thought it might be good to talk a little bit about staging and the scans, since we've kind of been talking about those. I don't know if we had should we move on to that?
Yeah.
Okay.
Yeah.
The listeners are gonna have to bear with us while we figure out what this show is, but I think this is good. Yeah, this is good. So I thought it was fascinating for both of you, because Katie, you kind of said the same thing that a million people say, is why am I not getting a PET scan? Right. Everyone, for some reason, views a PET scan as like the best scan that you can get, which is interesting. And then like, Julie, I know you started with a PET scan because in the sarcoma world, at least at WashU where we were, like that's where I was and you are, that's kind of what we do for staging there. And so just to let the people that are listening that are patients or not doctors, so once you've been biopsied, right, the other part of diagnosis is getting what's called a stage. And you both have probably learned a lot about this online, but staging is really important for oncology. It does two things. One is that most importantly, it gives you sort of prognosis information. And that's actually the point of staging, like academically, like when people are put into a stage category, what that actually relates back to is this big handbook for every disease, for most every disease, not all of them, but most every disease. And it literally has, like, if the cancer is this size, that's one part of it, the size of the tumor. If the cancer is involving lymph nodes, that's another part of it. And then the last part is if the cancer has spread elsewhere, and we call those metastases. So it's tumor, which is T, N is nodes, and then M is metastases. So the TNM staging system is what we use for most cancers. And that's actually literally prognostic for most of them. And what I mean by that is there are studies that show if you are stage 1, the average cure rate or survival is this. If you are stage 2, it's this, stage 3, so on and so forth. That's not all we use these days. It's gotten way more complicated than that, but it's a baseline thing that you need, because when you go into somebody's office, when both of you went into your medical oncologist's office, it is a different discussion for a stage 2 versus a stage 3 or a stage 4, sometimes drastically different. And so to get that, once you have the biopsy, you need to find out where it is. And it's not always the same thing. So just to give an exact example, like you were wondering, Katie, why you didn't get a PET, but it's like, my guess is they wanted to look at the liver, and PET's actually a horrible test for the liver. And I think a lot of patients don't understand that we actually are a little smarter than we sound, because we're using the tests in smart ways to actually answer specific questions that we have. And so just to quickly like close the introduction of that here, is the discussion is like PET scans are really good for finding spots outside of where the tumor started in most cancers, and they're very sensitive, right? So like in the sarcoma world, they tend to light up a lot. And so like if you have small metastases elsewhere in the body, which can happen with sarcoma, those will light up on a PET scan and we'll see them easily. It's also a built-in whole body scan, so there's no confusion about what you're going to get when you order it. If I had kidney cancer, for example, where there was a concerning spot in the liver on a CT scan, which unless you do it in a dedicated way, it doesn't actually tell you the information you need. It just tells you whether you should be concerned or not. And if you are concerned, a PET scan is not going to help you. It's actually worse. And so instead you have to get an MRI, which is really the best way to look at the liver. And this isn't like medical advice, because really those recommendations can be changed depending on, like, some patients can't get MRIs for certain reasons. Sometimes a CT is fine and it's more easily available and faster. And so we'll just get that instead of an MRI. Sometimes insurance companies will reject what you try to get, and then you have to fight with them to get what you want or do something different. And so that's also a consideration. And there's some places where it's controversial. So like if there's a patient with rectal cancer sitting on listening, the PET scans are extremely controversial in rectal cancer, and they're often rejected by insurance. And so, that's a good example of where that comes up. And so it's funny to hear you both kind of mention that, because even in passing, Katie, you kind of said you were wondering why you weren't getting a PET scan. Did that come because you saw it, you were reading online and you saw people talking about PET scans? And
yeah, so that's what I was going to mention. Like, I know now, like, I know for kidney cancer specifically, like, the scans kind of vary, but like some subtypes of kidney cancer do get PET scans, and some types of kidney cancer get CT scans. And then obviously, like me, because I have liver involvement, I'm usually getting MRIs. So kind of everything that you recapped is things that I slowly learned over time, but I see it all the time in patient support groups. And it's also like, I didn't know anybody diagnosed with kidney cancer, but I had people I knew that were diagnosed with other types of cancer, and I knew that they had PET scans. And so I didn't understand why I wasn't getting a PET scan from that context. And I see it all the time in patient support groups. I wish that was something that was like, there's so much information that you just can't possibly communicate that all to a patient right up front. But I really wish a lot of this information existed so patients could understand a little bit more, like know the boundaries of how to understand their disease in their context.
yeah. And I think the other thing that comes along with people wanting a PET scan is, when I was a medical student, it really took me a long time to understand, like, why would you not want every test possible? Right. Like I literally fought with an evidence-based medicine teacher about, like, how could you say that, like, if my mom gets cancer, I want her to get every single test that you can get. Why would you not want the information? Well, Julie, why don't we recap? I mean, like, you had a PET scan, and then you told us already that they found these things in your legs, right? And then I can't remember, you had to go get like ultrasounds or something, right?
I had to go get MRIs on both of my legs to rule out that those were cancerous spots.
And they were like nothing, right? They just ended up being, or I can't remember what they ended up being. Yeah.
I don't remember nothing.
Yeah. If you don't remember, functionally, they were nothing. So it's,
yeah,
right.
No, they really were some like random thing that it was nothing to be concerned about at all.
Yeah. And I think that, like, people don't really understand this until they experience that, because the reality is that false positives are a real life thing, and they happen with enough frequency or enough, like they're so common that like if you are a doctor who does PET scans, you order them on all your patients week in, week out, you're going to end up with somebody that has a false positive. And when you have a spot on a PET scan that they're like, this is probably nothing, but we can't rule out cancer, you can't just like leave it. You have to investigate it. And so then you've bought yourself another test. MRIs are, I think for patients like both of you, you can do MRIs and tolerate them, or maybe they're scary for you, but a lot of patients struggle with MRIs. They're expensive. And then sometimes we have to go even further and do biopsies or things that are more invasive that have real side effects. And so I think that, I try to always talk with patients around their diagnosis about how doing additional testing could actually be harmful. And there's no expectation that it can improve what we know. And I can imagine that's very frustrating and disappointing to hear as a patient, but I think it was just a hard concept that I like to try to teach people because it was hard for me to learn it. And so I try to make sure people understand that.
So one question that I have is there always some type of scan that happens after a cancer diagnosis? So the reason I'm asking is I was talking to someone not too long ago who had received a biopsy and got a cancer diagnosis. And that was essentially all they were going to do. There was no other, it was like, I don't really know how, but they felt like the physician felt like, no, we know your stage. And it's a very common cancer type, but they felt like, no, we know your stage. There's really no reason to do any other type of scan. The patient actually pushed for and got a PET scan, and there was, it didn't show anything. But I've always been curious. I always felt like after there's a biopsy, there has to be, you talked about the staging system, and there would have to be some way to rule out metastatic disease. And isn't imaging the way that happens?
Yeah. So this is funny because Katie, you have a cancer that's never, ever, ever supposed to metastasize.
Yeah.
So what we'll always tell people is that cancers don't read textbooks. And so like everything is theoretically possible, but there are cancers where we wouldn't scan because, so a great example would be certain types of skin cancer. You can see it with your eyes. And so like the tumor staging, you can just like literally measure it with a ruler in clinic. And like, that's easier on a patient than doing anything. And so I think that we'll sometimes do that. And then the fact that it quote, doesn't metastasize, the value of a test is very low there. And so there are certain situations where the risk of a false positive is higher than the risk of finding something that's relevant. And so in that case, you wouldn't blanket scan people, or you wouldn't scan people as like a rule in your clinic.
Sorry, go ahead. I was going to say, I've seen that happen for like earlier stage kidney cancer patients as well too, like patients that I've spoken with that have like very, very small tumors on their kidney, like a centimeter or less or something like that. Or even like under 3 centimeters oftentimes. That if it's like a really small lesion, I've seen some patients that like they got their initial scan that might have found that maybe that was an ultrasound or maybe it was a CT scan that actually found the tumor. And then they went straight to surgery to get it taken off. And then they might rescan afterwards, but they don't do like, some of those patients haven't done like chest CTs or anything like that because the likelihood of it spreading when it was in that small of a tumor, I think didn't warrant, I think kind of what you just mentioned, Matt, of like the risk wasn't really worth it for those patients.
Yeah. And one thing that's like really important for people to remember, we will come back to this multiple times, I think, because it keeps popping up in a lot of medicine. It's that there's kind of a push and pull, right? You want to do personalized medicine for your patient as best as you can. That's like kind of what we all try to do as oncologists. But then at some point, you also want to do high quality clinical medicine by having good, like set pathways in your clinic and set rules for how you do things, because you want every patient to get like the same care, right? And so when you're making decisions about, with this person, with this cancer, with this stage, what kind of scan do I do? You have to make rules about the population, right? And so when you do that, you're thinking about the risks of false positives. And if I do everything this way, what's going to happen? And so if you take if 99% of the time it doesn't metastasize, then if you start scanning everybody, you're going to end up having false positives hurt you in the long run. If you have a cancer that does metastasize a lot and you decide not to scan people, you're going to miss things. And so you need to think about that like push and pull of what's going to happen to the group of patients that you're caring for. But then at the same time, you have to always remember that there's going to be a patient that comes in that's going to be like, see, I told you this can happen, because you never want to rule anything out. And so it is a push and pull, and it's really difficult to do this well. The other thing that's really funny is I think that a lot of doctors are really informed by their experiences, right? And so if someone like your ER doctor, for example, Katie, that diagnosed you, like that's a crazy rare thing. And like the next time someone comes in, young woman with like abdominal pain, they're going to probably do that ultrasound, because you just like remember those cases, and it definitely like informs your future practice. And so you end up with it's this, to me at least, is something I think about a lot, and it makes me feel like I'm never doing an A+ job, because you're always either trying to do the best clinical scientific thing for the group, and then you feel like you let a patient down, or you're trying to do the thing for the individual patient, you're doing the wrong thing for the group. And it's a very challenging thing that we face, I think. Yeah.
I mean, my case is probably like the perfect example of that. In particular, like oncocytomas are, my case is super, super rare. And they don't typically do follow-up imaging on oncocytomas. Unless like you have a genetic condition or something like that. Oftentimes they just remove the tumor because it's not known to be cancerous. And then those people don't typically have surveillance. If you were to add surveillance to all of those patients, because my case ended up being metastatic, like you're obviously doing harm for those patients. They don't need the surveillance. And so I think that kind of speaks to the, like, if you were to take an individual case and apply it to everybody, obviously there can be harm through that. I will say though, like, I'm glad that you kind of talked about it as a balance, because I did also fall on the other side of that. Like as I was going through the diagnostic process, I was the patient that fell between the cracks. I actually had a physician that told me one time, because I kept asking for a scan. I didn't really know. I just like kept asking, like, can we rule out cancer? Can I get a scan? And I had a physician that was communicating exactly what we're talking about here, about like finding something that's a false positive. But he said, you don't want to scan because once you find something, like you can't go undo that. And I know what he was, and he said something about like everybody has something. And so what he was trying to communicate, I think, is exactly what we've been talking about here, is like there can be false positives, and then you have all these other tests that you have to go along. But in my case, had we scanned me, we would have found something, and it would have been found a lot earlier. That was like a year before I got diagnosed.
And what a thing to say. This is, I mean, like this, I hope there's probably some doctor out there that's criticizing something that I did appropriately so, because it's so easy to armchair quarterback this stuff. But like to have someone come in and say, I'm really worried I have cancer, and then for them to say everyone has something, it's just like, yeah. So that's tough. And I think, but the point is that it's true, but you have to like communicate it in the right way. Otherwise it just is enraging for people, because like, I think everyone feels that they should have all the tests that they need. And I think it takes it's not an easy thing to wrap your head around, that more testing can actually be bad. And like I said, even as a medical student, it took me a long time to really get that. Yeah. And so it's something that's a good lesson, I think.
Yeah, I think also communicating, like patients being more educated to be able to like make requests. I think like that's one thing that if I look at my diagnosis, and one thing that I wish I would have changed, or wish I would have been just more educated about how the health system and stuff like that works. When that physician told me that, I know some of the concerns too were like costs and things like that. As a patient, I was willing to pay those for the peace of mind of like, we've ruled this out. I would have paid for that. And I also would have accepted the risk of a CT scan, because CT scans were brought up multiple times through my diagnostic process, and nobody was willing to put me through one because they said, you're too young. The risk from radiation exposure is too high. And now that I know where that risk level is, I much would have rather been put through that scan. Hindsight is going to be 2020, but I wish the communication would have been there so that I would have been able to make that decision and would have known that I could push back and say, like, I'm okay paying for this if I need to, or whatever it was to get those things taken care of. But I think I guess I'll be conscious on time here, but I think speaking to that same topic there, as a physician, sometimes your hands are tied as well. And obviously probably not in the oncology space as much because you usually have a patient that has a reason to be getting these scans. But especially in like, I think primary care, you have to have like a reason you can point to say like, this is why we are ordering that scan, so that insurance doesn't deny it as well too, right?
Oh yeah. No, I love this topic. Julie, I know you're going to get fired up on this one for sure. This is a big deal actually now, because so what you're talking about specifically is that the doctor, the patient, or both may want a test to try to help do something with, like either diagnose or, give a prognosis or predict or pick a treatment, that kind of a thing. And then they get pushed back and the insurance company doesn't approve it, or the company doesn't approve it, or things like that. That's a big deal. And I'd say that's actually going to become a bigger problem. Right now, there's actually rapid development of new technologies that are helping with diagnosis. And I'd say it's hard to put these all in, like, we're not going to cover them all now, but I think it's like, genetic testing or tumor genetic testing to look for like targets that you can treat with medications, or they have like circulating tumor cell tests where you can find tumor cells in the blood, and that helps you decide if there's active cancer, or you can diagnose that way. And the reality is that there's a lot of motivation to develop and sell these tests. These tests are addressing problems that we've faced for a long time, and we are very frustrated about these problems. So doctors are excited about the tests, but they're not yet proven. And what that means is that what they claim to do, they may do in some settings, but not others, or they may not do in a study yet, that kind of a thing. And I would say that these days, more and more, there's like things are just moving fast. And so I think there are going to be oncologists out there that patients land with that want to order tests, and the insurance may push back, and then they have to decide if they want to get it out of pocket or whatever. And so that I think that I don't really know what to say about it, because I do think we are moving a little fast, is my own opinion. I think there's a lot of financial motivation to like develop and sell these tests, and so I think that's having a big role. But like, I know Julie is a great example. You've been following the ctDNA space for quite a while, right? And in the sarcoma world, this is, just so people know, this is circulating tumor cell DNA. There's different versions of it, but it's essentially trying to detect very small amounts of cancer or cancer DNA in the blood for the purposes of seeing if there's still cancer there, or if, how much cancer is there. And in the sarcoma world, we struggle a lot with that problem, like just detecting if things are there and if we need to treat or not. And so that test is like going to be awesome. And we're very excited to have it, but it's early days, right? And so I think if an insurance company pushes back and they were like, we don't want to pay for this, or it's not FDA approved or whatever, then that's where you run into the problem. And so that's a good example of something, that's a kind of an emerging test, and kind of have issues with it. I don't know if Julie, if you have anything to like add on that specific topic or to that question and answer. I don't know.
No, I don't have anything to add.
Yeah.
I mean, I don't know that. I don't know what the answer is. There's, I can see the utility of something like ctDNA, and I can see in my own case how I wish that we would have had a test like that after my surgery, that would have really helped inform whether or not I needed additional therapy. So I could see from my perspective how something like that will be really useful when the time is right. I also understand that it's the early days, and there are a lot of false negatives with those tests.
Yeah. And
So
we should actually have shows about all these things, I think. And we should
yeah,
talk about ctDNA is a big enough topic that we'll probably talk about it separately because it's having a big impact. One thing I wanted to say though is like the push and pull is here again, right? Because you understand, I mean, patients probably even more than doctors in the sarcoma world understand why we need this. Like it's so frustrating to not have an answer to this problem. And so I understand why everyone's excited about it. That's easy to see if you experience the space. But I've also seen a lot of tests. I've only been out in independent practice for about 5 years now. And I've seen tests that have been promised to be like the test that's going to solve this issue. And they never really make it to market because they just don't pan out. I think that, cancer is very complicated and it seems so simple sometimes. And I think that we expect these solutions to work and they don't always work,
Yeah. And, I think the other thing that's hard for patients sometimes is when you have a patient that is really well connected with other patients, you suddenly realize that different physicians have different thresholds for the risk in some of these tests. Like I know there are some sarcoma physicians that order these tests regularly for their patients. And there are others that have drawn a hard line and, it's just not ready for prime time yet. And so until it is, we're not using it. And so I think that's another thing that sometimes is hard for patients is just hey, this person over here is using it with regularity and this person's not. And why isn't there some standardization here? But, I think that's just what happens too when you're on the forefront of some of these emerging technologies. And
have you had anyone change their opinion? Like, have you had a doctor that you talked about this with, and then 6 months later they changed their mind about it? Because I do that sometimes.
No, I haven't. But no, I haven't.
Maybe I'm just impressionable. I don't know. I feel like it's just I really am interested in like the practice of medicine and these kinds of discussions and questions. And I'm like always open to changing my mind about things. And so, yeah.
I feel like this needs to be our second episode. It needs to be on second opinions and these testing and stuff like that. And kind of what you mentioned, Julie, of like comparing and contrasting treatment and like treatment decisions, because obviously it varies. Like, I mean, I've had so many different opinions on my same case, and you had very similar experiences, Julie, of like different answers for the exact same thing. And so I feel like that would be a really good episode for us to include in all of this. And I think testing falls into that category. It could probably be its own category of its own, but I think it falls into that category because there's so many new tests, and it's what do you do with the test? What do you do with the information when you get back from it? And I think there's a conversation around like what the physician does with that information, as well as a conversation around like, what does the patient do? Like, I can't tell you the number of, I was this patient where I got my like NGS testing back and I was like, what is NGS testing? What do these words mean? And like, can
we do an episode on that?
Yes. Because there wasn't resources really for me to even look that up either. But I think that plays to the fact that like this is so new that a lot of that information and those resources aren't there.
Yeah, we definitely should. Yeah, we could have a long one on that.
Please, that one has to be. We have to do that. I got some good stories there.
Yeah. No, I think especially in rare cancers, like the NGS is next generation sequencing. I think, right? And so and that's one, again, that's another one that we're doing more and more of. And if you go on Twitter and you look at doctors talking, there are very well respected, prominent doctors that make the point that testing has not actually been shown to improve outcomes. And I think that, again, it's one of these squishy areas where you're like, well, how could it not? I mean, how could it not give a better outcome if you know specifically what kind of cancer you're dealing with genetically, instead of just like calling it something? Like in Julia, in your case, the name of your cancer it means nothing. It literally means you don't know what it is, and it looks funny under the microscope. That's all it tells you. And so it's like I think, but at the end of the day, like we have the scientific method, like the one you learn in grade school, and we have that for a reason, because that's how you actually find truth. And I think that it's important to make sure we find that, but understanding that we're doing this in a world where patients are dealing with cancer today and they need answers today. And so I think that's the big challenge. We'll definitely, we got to do a show for sure. We'll do another episode.
Yeah. So should we wrap up the episode there?
We should.
We're teasing the episode we're going to do.
Do we have any closing thoughts? And I don't remember how we were going to close these. We can just end it. I guess it was, yeah. I thought this was great.
Yeah. I'm excited about this. I'm excited. I appreciate everybody kind of bearing through our like navigating of how we're going to do this, but I think the dialogue here is the most crucial part. And so I'm excited to talk about these things and be able to have this dialogue going through future episodes.
Me too. Thank you guys for sharing. All right. Well, so we'll be back with another one soon, and we'll keep going from there. Thank you guys both for coming on. We'll keep going forward. Love it.
Sounds great.
All right. Thanks. Bye.